Good evening, sir.
I think we can start. It's 8 o'clock.
Yeah. Uh, Hello, everyone. This time we will review the important journals which we discussed in the year 2024. Before that, I would like to invite Professor Manjusha Yadla, who is the guest panelist and the moderator for this month's journal club. Good evening, Dr. Manjusha. Thank you for joining in. Madam, I think you are muted.
Yeah, hi, good evening.
Good evening.
Thank you so much. Yeah.
Covering all the journals which we discussed in the 2024 would not make justice for the next 30-40 minutes so we decided to select a few things which would concentrate on certain topics. So one of the topic we decided to choose was minimal change disease. So not much was done in the last few years in terms of therapy or in terms of diagnosis when it comes to minimal change disease or FSGS. Yes, a lot of things were done with terms of membranous identifying newer antibodies, antigenic targets, but not much in terms of minimal change disease. And we also know the year of 2024 was dedicated to IgA nephropathy, where a lot of molecules came with IgA nephropathy. So we thought we'll select these topics, and this will also be a review for some of the DM or the DND students who are taking up the exam this year. This may come as both in their theory as well as their practical. So we just thought to discuss this topic for this. I'll start with the outset. I'll thank the ISN for the opportunity and continuing with the journal club. I'll share my screen and I'll start with my first journal. I would be discussing more on the minimal change disease, and Dr. Arun will speak on IgA nephropathy trials in IgA nephropathy. Okay, right. So we have now moved on to the personalized management of podocytopathies. So I would start with the what has been done in the last year. So previously, when we spoke about minimal change disease or nephrotic syndrome in children, especially in children, we actually divided them into either the steroid sensitive ones or the steroid resistant ones. In adults or even in children more than 12 years, we did a kidney biopsy. We identified if there is a minimal change lesion or a focal segmental lesion, and we labeled them as podocytopathies, and we again started them on steroids. So at the end of the day, what determines is whether this person is steroid sensitive or steroid resistant. Now moving on to the more personalized management, where we are more where we need to address the dependent ones, the steroid dependent or the resistant ones. We try to understand what is the pathophysiology behind it, whether it is the immune dysregulation, whether it is the autoimmune phenomena, whether it is the circulating factor or the genetic factor underlying it. Because if it is a genetic factor, there's very hardly any role for using more immunosuppression in that. If it is steroid resistant, then we start the second line of drugs. And if it is child is or adult is not responding to them, we label them as a multi-drug resistant. And often they progress to end-stage kidney disease. They may need a transplant. Now we are worried whether there would be a risk of recurrence in them. So the two important articles that were published in 2024, which actually looked into the incidence of recurrence, when to suspect a recurrence, and who are the patients who respond to such line of drugs, was the one which was published in NEJM, and the second article would be the one were published in KI. So I'll not be talking, when I told about the personalized treatment for podocytopathy, I'll be only looking into the MCD and the FSGS pattern and not the other varieties, and not the other histological varieties. The first article was discussed in our journal club. It was the autoantibodies targeting the nephrin in podocytopathies, published in NEJM in the May 2024 by Hengel et al. So basically, we do know that there are intrinsic factors and extrinsic factors for podocytopathies. Intrinsic to either the slit diaphragm or some of the circulating factors. Extrinsic factors being infection, certain toxins, or certain mechanical factors like hyperfiltration injury. So the group thought that there is a need to discover appropriate assays as well as a pathogenic role for antinephrin body in podocytopathies. So they previously the estimation what they used to use either the Western blot or ELISA. So they were not very happy with the pickup rate with these assays. So they also wanted to discover appropriate assays to both for qualitative as well as quantifying the antinephrin antibodies. And they wanted to use this assays to determine patients who will have response to therapy or who will have a recurrence of the therapy based on the levels of these antibodies and to determine whether urine albumin creatinine ratio or the recurrence of the disease could be correlated. They wanted to address all these issues and they went ahead with the studies. It was a multicentric studies across Europe and it was an exploratory study. So uh, patients were enrolled through the glomerular nephritis registry from Germany. Patients who had samples, either serum or serum samples from patients, only those were included. There were 357 patients from the adult registry group who had an immune-mediated disease. There were 33 pediatric patients from Italy from one center, 118 adult patients, and 5 pediatric patients in another center from Italy, and pediatric patients from France were included. For controls, they took 50 pediatric patients and 60 healthy blood donors for adults as controls. So basically, you need to have a serum sample so that antinephrin antibody can be tested in them. Adults, all of them had a biopsy, while pediatric, it was more of a clinical diagnosis if they had a nephrotic syndrome. So to generate the nephrin antibodies, they used the ectodomain of the human and murine nephrin, and they were cloned, and there was a recombinant protein. Constructs were expressed in human embryonic kidney cells. They also did the experimental study in them, in which a rat model was used. I'll describe about it in later slides. To identify the nephrin antibodies, they used what is known as the immunoprecipitation method because they found that direct Western blot, as well as the ELISA were not great in trying to pick up the both as a qualitative as well as a quantitative. So they used the immunoprecipitation method. So, autonephrin antibody status was determined both for qualitative using immunoprecipitation. For quantitative, they used a hybrid assay in which immunoprecipitation was combined with ELISA for quantitative. So you can see this is how it read. If you can see, there is highlighting of the dark black lines whenever in the MCD and the FSGS group, highlighting the presence of antinephrin antibodies. That specific line was not identified in groups with membranous or IgA nephropathy. Coming to the results, so you had a varied group of adult as well as pediatric population, and in adult population, they were all biopsy proven. And if you can see that patients with minimal change disease at the highest group with antinephrin antibodies, followed by FSGS. And if you look into the membranous IgA, ANCA, among other diseases, both antibody-mediated diseases, they were negative for antinephrin antibodies, co-localization of antinephrin antibodies. So this highlighted the specificity of antinephrin antibodies for minimal change disease and primary FSGS. So these were the two large groups in adults. Coming to the pediatric population, similar results were observed, wherein children with idiopathic nephrotic syndrome, 52% of them had antinephrin antibody positive. So one thing, it is not a universal to have antinephrin antibodies. The percentage is lesser in children. It is just about 50% may have antinephrin antibody positives, while in adults, if you can see in adults, it is much lesser. It is around 40%, 40 to 45% adults have antinephrin antibodies. Coming to the, I mean, this is just a pictorial representation of what we just discussed. The MCD and the primary FSGS had a higher antinephrin antibodies in their titers, and in children it was the idiopathic nephrotic group. What is interesting to know that it correlated with the urine albumin or the urine protein creatinine ratio. So as the levels of antinephrin antibodies increases, so it is not just a marker, it is also a quantitative marker similar to probably APLA2R in membrane. The levels of antinephrin antibodies correlated with the higher urine albumin creatinine ratio, lower serum albumin, higher serum cholesterol. So these were classically, I mean, there was a linear relation when it comes to urine albumin creatinine ratio and antinephrin antibody titers. So what the authors wanted to look is they wanted to follow these patients, what happened to them over the years, and well, the presence of presence of antinephrin antibodies. How did they behave with those without antinephrin bodies? So, the presence or absence of antinephrin bodies were associated with an active disease and remission, respectively. So, if they were positive for antinephrin antibodies, they had an active disease, and if it was negative with therapy, they were under remission. So, there was a linear curve, as we suggest, and there was a strong correlation between all measured antinephrin antibody levels and the urine albumin creatinine ratio. So this is what MCD, FSGS, if you look at the antibody titers, which this was a quantitative titer because that is the reason they have used immunoprecipitation and an ELISA hybrid assay. And if you see as the antinephrin antibody levels increases, so does the urine albumin creatinine ratio or the protein creatinine ratio. So it's more of a linear pattern what you see. But this is interesting what the authors observed. I mean, 3 patients were treated with rituximab, and what they observed, especially on a longitudinal follow-up, what they observed is as soon as the use of rituximab was used in these patients, the titers of antinephrin antibody dropped. Also to note important is as the antinephrin antibodies rises, so does the urine albumin creatinine ratio. The brown lines are the antinephrin antibodies, while the black ones are the urine albumin creatinine ratio. You can see that the antinephrin antibody and the urine albumin creatinine both rises together. And once the rituximab was initiated, you can see a prolonged remission achieved, both in terms of antinephrin antibodies as well as the urine albumin creatinine ratio. So this was one of the patient, and this is another patient, and the third. So 3 patients usually, 3 patients received rituximab, and all of them had beautiful response, both in terms of decline in antinephrin autoantibody levels as well as achieving remission clinical in terms of albumin creatinine ratio. So they wanted to replicate the same model in mice and see whether having antinephrin antibodies induces proteinuria. So what they did was they had the mice, they injected subcutaneously, they injected the nephrin antigen, and they measured, I mean, the rats were sacrificed, and later their blood samples were taken for measurement of antinephrin antibodies. So what they could identify is, yes, they had proteinuric stage after development of antinephrin antibodies, and they hypothesized that nephrin, the presence of antinephrin antibodies increases the phosphorylation of the nephrin antigen. So there is phosphorylation of nephrin, and with phosphorylation, what happens is there is an increase in clarithrine and SHCA. What this does is it causes endocytosis of the nephrin. So what there is a nephrin endocytosis as well as the slit diaphragm. The proteins associated with the slit diaphragm are downregulated. So there is endocytosis of the nephrin as well as other proteins along the slit diaphragm are downregulated. This results in the loss of functional slit diaphragm, and this behaves like an MCD kind of a thing. Unlike what you see as an antigen antibody complex in terms of membranous or in other diseases, what you see here is endocytosis of the nephrin, downregulation of the slit diaphragm proteins, and loss of functional slit diaphragm, resulting in an MCD-like pattern, what you see in case of antinephrin antibodies. So What there is identified is both adults and children. Up to 50% of patients had the presence of anti-nephrin antibodies. More common with minimal change disease and fewer with primary FSGS in this. So prevalence of antibody was 69% and 90% in patients with NCD and idiopathic nephrotic syndrome with active disease before immunosuppressive treatment, respectively. So this number is high, and especially in patients, adult patients with an NCD pattern, and in pediatric patients with idiopathic nephrotic syndrome, they have a very high incidence of presence of anti-nephrin antibodies prior to treatment. Similar results were appreciated in other studies. Watch et al. In 2021. Some of the studies from Japanese studies, they identified as high as 46% of patients having anti-nephrin antibodies. More importantly, if you look at the last study, this was the cohort of recurrence, and they identified out of the 14 patients of pediatric FSGS patients, 14 pediatric FSGS patients who had non-genetic. I mean, the entire total cohort was 22. 8 had genetic, and 14 had non-genetic cause for FSGS. In them, 11 had anti-nephrin antibodies, and they had a very high recurrence following transplantation. So remember, even after recurrence, the presence of active titers of anti-nephrin antibodies resulted in high recurrence rate. So anti-nephrin antibodies acts as a new and reliable marker for monitoring disease in anti-nephrin-associated podocytopathies. 3 patients with nephrin-associated podocytopathies on rituximab turned out to be negative, both in clinical remission as well as antibody titers decreased. Thus, having a more probably a patient-centric approach, more personalized regimen, so that indicating that if there is anti-nephrin antibodies, rituximab probably is the first line of therapy because it reduces anti-nephrin antibodies and induces remission. Immunoprecipitation technique was more suitable, and if someone is planning to start, I mean, if their lab wants to start, I think it's a right way to go ahead with immunoprecipitation, because the authors actually experimented with both Western blot as well as ELISA, and they found that a hybrid technique of immunoprecipitation with ELISA was better for quantitative, and for qualitative immunoprecipitation assay was the best. So it provides a non-invasive alternative, especially in pediatric patients below 12 years of age in whom we do not biopsy, and most of them we see them responding to rituximab. In fact, rituximab, someone who is dependent or frequent relapsing steroid, rituximab has been the main therapy before CNIs of late. The pathogenicity of anti-nephrin antibodies was well illustrated in this study, even in the animal model, which clearly and they could identify the phosphorylation of the nephrin, especially in the tyrosine Y1191 area, as the critical step, resulting in nephrin endocytosis and resulting in downregulation of the proteins along the slit diaphragm. All of this resulted in MCD-like picture, podocytopathy like a picture, without triggering the traditional immune response. Because this is one thing, if there is an anti-nephrin antibody, why is it not triggering the traditional immune responses? I mean, the way it works is slightly different from the antigen-antibody reactions, what we see. Another important thing, what the strength of the study was the longitudinal nature, where they could see what happens to these patients, positive patients, negative patients, and animal model was used. They could identify that using the phosphoproteomics, they could identify what was the pathogenesis behind this. Why is it not behaving like a typical antigen-antibody complex? Why the mechanism is different, they could identify with through this, and they also identified the reliable technique how we can measure anti-nephrin antibodies. One important thing, I thought I'll just go through this. I'll just introduce this. I'll not go in detail. Why is it important? Because the next study also talks about, especially the anti-slit diaphragm also talks about these microscopes. Both the studies, the one published in NEJM and the KI, they use a high resolution fluorescence microscope, the confocal, and in the next they use the STED. STED is nothing but the stimulated higher resolution of confocal. It is much more higher resolution than the confocal microscopes. So these are some of the basic differences. Basically, for our basic understanding, laser lights are being used. You are blocking off using pinhole filters. Yeah, you are trying to block off some of the refracted lights, and you are trying to focus on the specimen what you want to view, and with a very high resolution. So you are seeing both live cells and tissues, and superior to that is the stent, which has been used in the group by Valentina Ragletini et al., where they use both confocal as well as the stent microscope to identify the anti-slit diaphragm antibody. So the hypothesis for this study was, yes, nephrin was already there in the market. The authors realized that there is an antigen antibody. It is not just a circulating factor. It is not just a immune dysregulation which is occurring because of the T cell mediated. There is something more. We have realized that there is an antigen antibody working in a different mechanism in MCD and FSGS. So they wanted to further explore this, and they've identified what is known as an anti-slit diaphragm antibodies on kidney biopsy. Both in especially they looked into steroid-resistant nephrotic syndrome, and again, as I told in the previous group, there was more of steroid-dependent and other class of idiopathic nephrotic, especially the minimal change disease, who do respond to rituximab. And now I am talking about steroid-resistant nephrotic syndrome group, who are more likely to respond to the second line of immunosuppression, including the CNI as well as the rituximab. So they so what they wanted to test is a non-genetic steroid-resistant nephrotic syndrome can achieve remission with second-line immunosuppressant, and what determines it? What determines that they can respond to second-line immunosuppression? This is what they wanted to look at. They knew that patient who responds to second line have a more favorable long-term outcome compared to those who do not respond, who are multi-drug resistant. So rather than having a trial and error method, why don't we have a personalized medicine, personalized care? We already had anti-nephrin antibodies. Now let's look beyond that. Rather than having a trial and error method, giving all the types of immunosuppression. So what they wanted to do is, let's identify the anti-slit antibodies on the kidney biopsies, and probably this can explain the autoimmune podocytopathies with the steroid resistance and who respond to second-line immunosuppression. So the authors had 128 pediatric patients who underwent kidney biopsy. There was again, these were more a pediatric group from 2010 to 2023. They had 5 age-matched healthy kidney biopsies. These was nephrectomized specimens for tumors. Again, in the same age-matched children between the same period, they just had five kidney biopsy specimens from nephrectomized specimens for kidney tumors. They they found that 62 out of the 128 had a podocytic pattern, that is a minimal change, or FSGS at the kidney biopsy, and 45 of them had a steroid-resistant nephrotic pattern on phenotype. So 68, there were 128 patients to start with. I'll go through the flow chart. 128 patients to start with. 62 had a podocytic pattern. 45 had steroid-resistant nephrotic syndrome phenotype. Out of these 45 patients with steroid-resistant nephrotic patients, frozen biopsy sample was available, were compared with all the remaining age-matched patients with steroid-resistant nephrotic syndrome. They were all followed up for the same period. They wanted to see how patients with anti-slit behave differently without them. They also assessed a validation cohort of adult patients who had received a histological diagnosis of minimal change or FSGS lesion pattern in the years 2016 and 2024. So they had an adult validation cohort. They had the main pediatric cohort, which formed the main core of their study. As I previously said, they used high-resolution confocal microscopy, which uses fluorescence. It is based on the fluorescence principle, using a laser light with a very high resolution, with a pinhole effect, and they also used a stimulated emission depletion microscopy, that is a higher resolution compared to the routine confocal microscope. They used ELISA for determination of anti-nephrin antibodies. So this is, they used immunoprecipitation in the previous study. Here they used the ELISA for anti-nephrin antibodies. So this is a flow chart: 128 kids to start with, 62 patients had minimal change or FSGS, and then 45 had steroid-resistant nephrotic syndrome pattern. 12 patients had a positive genetic test, and 33 had a negative genetic testing in these patients. So if you look at them, 50% patients had an anti-slit diaphragm, anti-slit antibody positive. 50% had negative anti-slit diaphragm. Out of the 33 patients, 50% had anti-slit, 50% did not have. So this is what we routinely follow. So we treat them with steroids. They become steroid pediatric with either we label them as steroid resistant. Once they are labeled as steroid resistant, we do a genetic analysis. And if they are genetic testing, we do not go further in that. We'll just go with the steroid genetic test negative group, which is about 60%. If you look at 45, 33 are genetic test negative. Two-thirds of the cohorts are genetic test negative, which is often what we see. Out of it, 50% are anti-slit antibody positive. This is in a nutshell. This is the infogram what we could see in patients. Anti-nephrin antibody positive and anti-slit positive. So 78%. In adult patients, there were 55 patients with both anti-slit and anti-nephrin antibody positive. So what happens to this? How do you, in steroid resistance, if you look at this cohort, it's the steroid resistance, you can see that 30% had anti-slit positive with a membranous, with a minimal change pattern, and 25% had an FSGS pattern. I'll just go through the results section. So looking into the results, immunoglobulin positivity of the slit diaphragm occurs in a subset of patients with minimal change or FSGS lesion. It is not universal. We could only see in about one-third patients overall who were steroid resistant, because one-third were genetic cases and one-third were anti-slit negative IgG positive. So to evaluate the possible binding of antibodies to the filtration slit, we labeled, the authors labeled the kidney sections for immunoglobulin and nephrin, and imaged them with a high-resolution confocal. They used 5 controls, which were the nephrectomized specimen, and they also used various immunocomplex diseases to identify if these anti-slit were co-localized in them. So overall, what they could notice is 30% of patients with minimal change and 25% of FSGS had IgG immunolabeling along the slit. So when I say IgG immunolabeling along the slit, we are talking about the anti-slit antibody positives, because they are not the anti-nephrin. Anti-nephrin is in the serum, and anti-slit we are using the IgG immunolabeling along the slit diaphragm in these patients. Adults with IgG deposition on the slit diaphragm in 68.4 patients were 68.4 patients with percent of FSGS on kidney biopsy specimen. Adults had IgG deposition that they were positive or anti-slit. So all patients in this cohort, unlike the previous cohort, had a kidney biopsy. That is the first difference. All these cohort had a kidney biopsy. And in them, if you can see that one-third of pediatric patients had anti-slit diaphragm, and more than close to two-thirds patients of adult patients had anti-slit antibody positive. Taken together, altogether, these results show the filtration slit defines a subset of patients with podocytopathies and minimal change in FSGS lesion pattern, undistinguishable with the routine pathology procedure. So if you look them with the light microscopy, you could either label them as an MCD or an FSGS, but you need to look further through high resolution microscope like the confocal or the STED to identify the presence of these antibodies. These are simple steroid resistant nephrotic syndrome cases. So similarly, conversely, 4 of the 18 cases, there appeared to be a lack of immunoglobulin along the slit diaphragm, and there was no nephrin co-localization at the slit. While as the rest, there was a localization of the nephrin in the immunoglobulin, in the IgG immunolabeling label staining. And this was on the confocal confirmed on the STED microscopy. Overall, this suggests that the presence of different types of anti-slit antibodies are present along the glomerular basement membrane. So serum immunoassay was used to detect the anti-nephrin antibodies. But again, as we spoke in the previous study, this immunoprecipitation is preferred in the previous group. But here, this is the classical what to quantify the ELISA method was used here. And probably some of the reason why the pickup rates were much lesser compared to the previous studies was because of the type of immunoassay that was used. 4 out of the 6 serum samples of pediatric patients were patients positive for anti-slit antibodies at kidney biopsy had a positive ELISA for anti-nephrin antibodies. 2 of the 6 patients with a negative ELISA had a positive slit antibodies. This is what they want to say that there are other antibodies other than the nephrin antibodies. So that is the reason they labeled them as anti-slit antibodies. This is what they try to identify in both in the controls as well as in the minimal change and in the FSGS steroid resistant samples. So if you can see, there is a co-localization of anti-slit and anti-nephrin antibodies. Okay. And if you look at the age match controls, which is here, and if you look at the 3 cases of minimal change and where anti-slit was positive and anti-nephrin was negative. So assessment of serum samples, these were the serum samples which were assessed. Assessment of serum samples in the second cohort of adult patients with minimal change and FSGS and age match controls and gave similar results with what was seen. So what the authors concluded was patients with anti-slit antibodies had severe nephrotic syndromes. I mean, this is different from the, they were much worse than patients with just anti-nephrin antibodies. Co-localization of anti-slit antibodies had a very severe nephrotic syndrome. Serum albumin was below 2 in 50% of patients, and hypercholesteremia was universal in all of them. Pediatric patients with anti-slit antibodies were frequently young, with 13 cases, that is about 3/4 of these patients were below the age of 5 years. Anti-slit antibodies associated with minimal change lesion pattern was seen in 55 patients and FSGS in 44% of these patients. So the most histological pattern was still minimal change in pediatric population. They had more severe nephrotic presentations and the onset was much lesser below 5 years of age. Pediatric patients with anti-slit antibodies showed lower rate of glomerulosclerosis and IFTA. And probably because these were the patients who were much, they were biopsied before exposure to the CNIs. And they had a much lesser IFTA and glomerulosclerosis. Patients with anti-slit antibodies present severe nephrotic syndromes with only minimal signs of chronic injury. So there is definitely hope that you should start the second line of therapy. Why they try to analyze the IFTA score is because is there a role to start using second line of therapy? Because if there is already IFTA, then probably these patients may not respond well to the second line of therapy because there was very minimal chronic injury signs. The authors were hopeful that they will respond to the second line of drugs. So this is further trying to talk about the protein creatinine ratio, serum albumin. So if you can look at that, positive cases had a lower serum albumin. As we moved closer towards the lower serum albumin group, we see more of brown lines, which is talking about the presence of anti-slit antibodies. Similarly, the more younger patients had anti-slit antibodies. Also, similarly, the histological pattern was explained. I think I've already gone through that. So I think if you look at the, I'll just, for the lack of the time, I'll try to skip most of the slides. If I have to go through some of the takeaways from this, takeaways, what I would say is we need to personalize the treatment. If someone has an anti-nephrin antibody, they do really respond to rituximab. And patients who have anti-slit diaphragm, they have chronic. I mean, the chronicity is much lesser in them. Even though they are steroid resistant, they are still amenable to therapy. If they are genetic negative, you should go ahead with the second line of therapy using either CNI or rituximab, and they do respond to that and the reason for that is the presence of these anti-slit antibodies. And I think there is more hope for future in these patients. The patients who are multi-drug resistant are the patients who do worse and who do progress to end-stage kidney disease. Patients with anti-nephrin antibodies have a higher recurrence rate if you are transplanting in the presence. They may need rituximab prior to transplant, reduce the anti-nephrin antibodies, and then go ahead to reduce the chances of recurrence of FSGS in non-genetic cases of FSGS. Thank you. Arun, you can start probably. I'm sorry to skip the few slides. Arun?
Yes, I think you'll have to stop sharing.
I'll stop sharing.
So I think I'll also present my part of on IgA nephropathy, and then probably we can have a discussion. A very good evening to everyone. So, having listened to about how things have changed in MCD, I still believe that the year of 2024 has been of IgA nephropathy. So, as we all know, IgA nephropathy is the most prevalent GN. Though being the most common type cause of glomerulonephritis worldwide, our understanding is still limited, and our therapies still are based on only optimal supportive care. The four-root hypothesis, which has been there for quite some time, is evolving, and we have understood that there is a significant component of inflammatory component which is there in the pathogenesis, which can be targeted with newer agents. So, though the present therapy is limited to steroids and supportive therapy, we believe that the complement components and the treatments targeting them are going to change the outlook of IgA nephropathy in the years to come. Till now, our aim of therapy would be to optimize supportive care and to bring down the proteinuria to zero point 0.5 grams per day using RAS inhibitors or SGLT2 inhibitors. For those with a rapid progressive CKD, a 6-month course of glucocorticoid therapy is something which has been advised by the KDIGO guidelines. There is an unmet need because for patients who are going to not fit into the criteria of progressive CKD or rapidly progressive GN or a chronic IgA, and they have persistent proteinuria and are not in remission, we rely on the use of either prednisolone or MMF in these situations. And even after that, most of the patients do not respond, and we are not able to give them therapy for a longer time. This is where the newer agents are going to come into play in IgA nephropathy. 2023 has been a great year for IgA, last year per se. 2023, where we had the sparsentan study, which had shown very clearly that sparsentan, which is a dual endothelin angiotensin receptor antagonist, had a meaningful reduction in proteinuria, which was 49% as compared to the standard of care at present, the ARBs of only 15%. And because of this, they have got accelerated FDA approval for use in IgA nephropathy in United States. Also, we had the Nefiga trial, wherein targeted released budesonide of 16 mg had shown a significant reduction in proteinuria with a very good preservation of renal function. eGFR decrease was much better with reduced adverse events, and this also got the FDA approval in 2023 for the same. Also, we had the sibeprenlimab, which is a monoclonal antibody targeted against April, which is involved in the pathogenesis of IgA nephropathy in the ENVISION trial, where it had shown that there is a significant reduction in proteinuria, and this was a phase 2 trial. The phase 3 trial, namely Visionary trial, is something which is ongoing now. This was what was 2023, so that was also a very eventful year for IgA. In 2024, something which in the later part of 2024, we had the first major article, which I'd like to discuss, would be the iptacopan, the alternate complement pathway inhibition with iptacopan IgA nephropathy, which was published in NEJM in November 2024. So overall, the complement cascade is getting activated using the classical lectin and the alternative pathways, wherein there is activation of the C3 convertase and downstream activation of C5 convertase, which then activates the membrane active complex, which then causes the terminal tissue damage. There are a number of molecular targets which are right now available to target each component of the complement cascade. What we are going to see is iptacopan, which is the oral first-in-class highly potent inhibitor of factor B. So what iptacopan does is that it blocks factor B and thereby blocks the alternative pathway activation. And because the activation of C3 convertase is blocked, the amplification which happens due to lectin and classical pathways are also blocked. You should remember that it does not affect the direct signaling by the lectin and classical pathways. Only the auto amplification and the alternate pathways get blocked by iptacopan. So the phase 2 trial, which was published in 2023 again, it had shown that the usage of iptacopan was associated with a significant reduction in proteinuria by around 23% and also a significant reduction in the alternate complement activity. And this formed the basis for the present study, the applause study. So the applause study is a multi-center, randomized, double-blind, parallel group, placebo-controlled study where iptacopan was evaluated in IgA nephropathy patients. The sample size was around 450 patients, of which 20 patients had a EGFR less than 30, whereas the other 430 patients had a EGFR more than 30. And the dose of iptacopan which was studied was 200 mg twice a day, compared in comparison to placebo. It was conducted in 32 countries, of which India, multiple centers in India were also part of the study. So from this study, the patients were, after screening, they were randomized into 1:1 faction into oral iptacopan versus placebo. During randomization, the stratification was done according to the geographical region, baseline proteinuria, and EGFR. This ensured that there will be an optimal distribution of patients across all the groups. The inclusion criteria included patients with IgA nephropathy, biopsy proven within 2 to 5 years. For patients with EGFR up to 45, the biopsy had to be within 2 years, whereas for others, it could be up to 5 years. The proteinuria had to be more than 1 gram, and the patient had to be on a maximum tolerated dose of RAS inhibition for 90 days at least. The vaccination had to be ensured because being a complement pathway inhibitor, the risk of infections with encapsulated organisms increases. The patient need to be vaccinated against Streptococcus pneumoniae, H. influenzae, and Neisseria. Mainly Neisseria is what we are concerned about. And during the course of the run-in phase itself, the patient can be vaccinated in this time. Patients with secondary IgA, those who had used any immunosuppressive therapy within the last 90 days, if rituximab was used, it should not have been used for the last 180 days. And if steroids were used, up to 10 mg was allowed. If at all more than 10 mg was used in the preceding 3 months, they were also excluded. Those with recurrent infections or active infections within 2 weeks of inclusion in the study were excluded from this study. The primary objective was to demonstrate the superiority of iptacopan in reducing proteinuria at 9 months by using urine PCR assessment. Secondary objective was to see the proportion of patients achieving a proteinuria less than 1 gram, to see the slope of EGFR decline over 1 year, and to know evaluate the safety and tolerability of iptacopan. So as you can see, patients were screened and they had to go through a compulsory run-in phase of 90 days where they were on the maximum tolerated dose of ACE/ARBs and they were not on any immunosuppressions. Thereafter, they were randomized into 2 arms, iptacopan versus placebo, which was continued up to month 24. And at 9 months, the interim analysis was done, which is being presented in this article right now. The trial is still ongoing, and the patients will continue taking the drugs or the placebo till 24 months, and thereafter there is an open label study. So overall, 1,188 patients were assessed and 471 underwent randomization. 443 were included in the trial, 221 and 222 in each arm. And 250 of these patients, the initial 250 of these patients have been included in this interim analysis. In this interim analysis, equally divided between iptacopan and placebo groups, you can see that 20 patients had 26 totally had discontinued iptacopan and 35 had discontinued the placebo. And of this, 7 patients had achieved the composite kidney endpoint in the iptacopan group as against 16 in the placebo group. And at the 101 patients are continuing to receive iptacopan, whereas 83 in the placebo arm, and around 407 patients have completed the 2-year phase already, whereas others, the trial is ongoing. The composite kidney endpoint, it was defined as a sustained EGFR value. Sustained means 2 values at least divided 4 weeks apart, wherein the EGFR decline is more than 30%. The EGFR is less than 15 ml, or if the patient is on maintenance hemodialysis, has undergone a transplant, or has expired. Going on to the baseline characteristics, both the groups are very fairly matched, and certain things of significance would be that the Asian population constituted around 51% in both arms, which is quite, very important because as we know, IgA nephropathy, the outcome of IgA depends upon the race. the phenotype as well as the outcome depends on the race. And this is important because most of the earlier trials did not have a significant Asian representation, apart from the MMF trials, which are basically from China. Most of the kidney biopsies were within 2 years. The MES scoring was given, and around 40% of the patients did have some amount of chronicity. Apart from that, both the arms were very well matched. With regard to the proteinuria, the patients had a mean of around 1.8 in both arms, and over 98% of the patients were on AC inhibitor or ARBs. The RAS blockade was nearly optimal in both the study arms. With regard to the blood pressures are also very well controlled in both the arms, and SGLT2 inhibitor use was seen only in less than 15% of the patients in both the arms. This probably is something which will have to be seen because the use of SGLT2 inhibitors has been increasing worldwide. Around 28% of the patients, around one third of the patients had received steroids, but not in the last 3 months in both the arms. So going on to the results in the primary outcome, it was seen that the patients who had received iptacopan had a significant decrease, a 38% decrease in the proteinuria as compared to the placebo arm. And with the first morning sample also, the difference was significant, a 35% decrease at the end of 9 months. And the supplementary analysis, the proteinuria, 24 hours proteinuria, albuminuria, and the albumin creatinine ratio is significantly different, reducing by around 40% in the iptacopan arm as compared to the placebo arm. Going on to the various subgroup analysis, irrespective of the geographical region, both Asians or all other races, they tend to have a good response with iptacopan. There was a trend to show that if the proteinuria at baseline was high, the response with iptacopan was better. But this is a trend, but not statistically significant. But overall, across all ranges of urine protein creatinine ratio, iptacopan was significantly better than placebo. Irrespective of the SGLT2 inhibitor use also, iptacopan was useful in both the arms. However, the percentage of patients having a SGLT2 inhibitor being used was very less. Again, irrespective of the MES scoring, iptacopan was useful. And the other question is whether if the patient has received previous immunosuppression, would the outcomes vary? No. Even when patients who have used glucocorticoids or other immunosuppressions, the benefit of iptacopan was significantly greater as compared to placebo. With regard to the complement pathway biomarkers, the Vicelab serum, which is a qualitative immunoassay for the alternate pathway, the factor B assessment, and the membrane attack complex assessment were significantly reduced in iptacopan arm, which is shown in mustard, as compared to blue in placebo, which shows that iptacopan targets the complement, and probably that is the reason why there is a reduction in proteinuria and better outcomes with IgA nephropathy. Adverse events were comparable in both the groups, and there were no deaths in the study till the interim analysis. So overall, it was also noticed that the proteinuria reduction after addition of iptacopan was rapid, and the effects were seen as early as week 2 and progressively increasing till the 9th month. And considering that FDA has now approved proteinuria as a surrogate endpoint for renal trial outcomes, it is likely that this is going to be seen mostly in all the trials in the future. And both the complement pathway markers are also reduced and the proteins are also reduced, which shows a mechanistic evidence that alternative complement pathway inhibition works in IgA nephropathy. The trial did not have any serious safety problems or infections, and it is still ongoing. Probably we'll have the full results after another 1.5 years, which is expected to be positive. Overall, the study had a very robust design, had a maximum dose of RAS inhibition, a very short time from biopsy, less than 2 years. So probably the MES scoring is important. And nearly 50% of the patients were from Asia, which is important for the context of this study. The limitations being that the interim analysis was not powered to confirm effects on renal function. So the effects on EGFR and others have not been reported. The SGLT2 use, though, was seen in around 15%, 11 and 14%, it's still limited. Probably it does not reflect the real world usage of SGLT2 inhibitors. So to conclude, iptacopan resulted in significant reduction in proteinuria as compared to placebo. And with this, it had got the FDA approval for use in IgA nephropathy. But something which we'll have to remember is it is not going to be available in India soon, apart from the trial usage and the cost. The listed price of iptacopan is around 550,000 US dollars, which is more than the acquisition cost, the company acquisition cost of Sparcenter also. So I would just like to say something about iptacopan. In addition to its role in IgA nephropathy, it is being developed or it is being studied in various other diseases, C3GN, PNH, atypical HUS, membranous nephropathy, and also Pepper's nephropathy. Something which happened in 2024 outside IgA is about C3GN. In 2023, it was seen that in patients with C3GN, iptacopan both in the native those with native C3 gene and also in recurrent cases post kidney transplant. Iptacopan had reduced the complement levels, reduced the hyperactivity, reduced the proteinuria, and improved the outcomes in these patients. And following this, the Appear C3G study was done, wherein around 74 patients were randomized to iptacopan versus placebo, analyzed interim analysis at 6 months, and then shifted to an open label therapy where both the arms received iptacopan. And the preliminary results were presented in ASN this year, in October 2024. And it was seen that the average age in both the groups were around the second and third decade, which is like the C3GN. Around 25% of the patients were Asians, which is good. And at 6 months, the proteinuria reduction in the iptacopan arm was 35% better than those on placebo. And this was sustained even at 12 months. The patients had a sustained reduction of more than 35%, 37% even at 1 year. And those patients who were shifted to an open label iptacopan, the proteinuria reduced after the switch by 31%, showing that whenever iptacopan is initiated in patients with C3G, there is a significant drop in proteinuria. The same thing happened in EGFR. EGFR is well preserved in patients on iptacopan and is preserved. And those on placebo, though there's the initial reduction in EGFR, once they are switched to iptacopan, the final EGFR which is achieved is good, which shows that iptacopan works well, preserves renal function in C3GN, and the safety profile is also comparable in both the arms. So overall, I think this is something which is going to get published this year, wherein iptacopan's role in C3GN is going to change the outlook of C3GN, at least in those with insurance coverage. Going back to IgA, the other major molecule which I would like to discuss today would be atacicept. This was published in Kidney International in April 2024. So this is the randomized international multi-center double-blind placebo-controlled trial of atacicept, which was conducted in 65 centers in 30 countries, and it was funded by Vera Therapeutics. And overall, IgA, the pathogenesis of IgA depends upon the production of galactose-deficient IgA molecules and autoantibodies to these galactose-deficient IgAs. So the BAF, the B cell activating factor, and APRIL, the proliferation-inducing ligand, they are usually involved in the function and the maturation of B cells and plasma cells, and also in the IgA class switch. And the elevated levels or dysregulated BAF and APRIL, they are usually associated with elevated levels of galactose-deficient IgA, autoantibodies, and immune complex formation. So what atacicept, what normally happens in IgA is that there is a B cell priming which happens in the mucosa. The plasma cells get activated through role of BAF and APRIL. There is a plasma cell mistrafficking to the systemic circulation. Galactose deficient IgA is produced, and the immune complexes with the autoantibodies get deposited in the glomeruli, causing progressive renal injury. Atacicept targets the B cell priming, targets BAF and the APRIL. It reduces the production of galactose deficient IgA and also the autoantibodies, and thereby reduces the immune complex. So it acts upstream in the pathogenesis of IgA, and theoretically it has to act better. That is what is expected. This study, it was supposed to evaluate the efficacy and safety of atacicept in IgA nephropathy and persistent proteinuria in those who have higher risk of disease progression. It included patients more than 18 years with biopsy-proven IgA nephropathy who have been on stable RAS inhibition for at least 3 months. SGLT2 inhibitors can be used. The proteinuria had to be more than PCR more than 0.75, and the patient had to have a EGFR more than 30 with a well-controlled blood pressures. The blood pressure control of 150/90 was taken as an inclusion criteria. Probably a very complete blood pressure control was not needed. Those with secondary IgA, nephrotic syndrome, or a rapidly progressive IgA were excluded from the study. The endpoints, the primary efficacy endpoint, which was shown in the study, is the UPCR at week 24. Secondary endpoints being UPCR at week 36 and EGFR change in week 96, the levels of gadolinium deficient, galactose deficient IgA, and also the safety profile of atacicept. So the patients, after screening, they were randomly assigned to a 2:2, 2:1:2 to various dose of atacicept, 150, 75, 25, and placebo. So all are two patients, whereas 25 mg has a lesser number of patients. It was just included to provide data on safety and biomarkers. Hence, the number of patients were limited. Total number of patients being 15 as against 13 each. So the patients had to be on varying dose of atacicept and placebo till week 36, following which there will be an open label extension up to week 96, where the patient will be on atacicept dose of 115. So in this trial, around 232 patients were screened and 116 were randomized and treated. Uh, Only around 5 patients are discontinued therapy, one due to hepatitis B DNA and one due to pericardial effusions. The other two explanation is not given, and the other data is available for analysis. Going on to the baseline characteristics, here again, nearly 44% in the entire cohort were Asians, which is good. However, one thing which is maybe problematic is that in the placebo arm, only 24% were Asians. So probably uh, the placebo arm did not have a very representative population of the Asian population. The blood pressure control, though necessitated only 150/90, the blood pressure control was fairly well controlled, less than 130/80 in the arm. And the average proteinuria in overall group was around a PCR of 1.6. With regard to the EGFR, almost most of the patients, more than 70%, tended to have a EGFR more than 45 ml. And the RAS inhibition was used in almost all patients. Dual RAS blockade was used in less than 10% of the patients. Here again, around 14% of the patients were on SGLT2 inhibitors, which was probably very less as compared to the real world data. Going on to the primary outcome, two types of analysis was done. One wherein the placebo arm was compared to a combined atacicept dose of 150 and 75 mg, and others with varying doses. It was seen that the reduction in proteinuria was 8% in the placebo arm as against 31% in the combined group. And with regard to individual doses, 20% reduction in the 75 mg group and a 34% reduction in 150 mg group. And as you can see, the effects were more pronounced. The difference was pronounced from week 12, and it was even more pronounced at week 24. So a further reduction is expected week 36. With regard to the GFR outcomes, secondary outcomes, the eGFR was maintained very well in the atacicept arm in both the doses as compared to the placebo arm, where there was a sharp decline in eGFR. Overall, the difference between both the arms with regard to eGFR between atacicept and placebo was around in the level of 11%, which was statistically significant. With regard to the galactose deficient IgA levels, there was a significant reduction in galactose deficient IgA levels on use of atacicept, wherein the levels reduced by 59% in the 75 mg dose and 64% in the 150 mg dose. And the treatment emergent adverse effects were not significant in either of the arms. It was not irrespective of the dose of atacicept, and infections were balanced. Though hypogammaglobulinemia was expected, there was no interruption due to hypogammaglobulinemia in the atacicept arms. So overall, the combined atacicept reduced UPCR by 24.5% in week 24 and 35% in week 36, and there was a stabilization of EGFR. So along with the other phase 2A study, which is Jan ISN study, had shown that atacicept in a population without concomitant immunosuppression was safe. It targets the underlying pathophysiology and reduces the galactose deficient IgA level significantly. Thereby, it should probably be better with regard to use in IgA. The strength of the study was that the patients had a good proteinuria even with optimal RAS use, so they were probably at a higher risk for progression. SGLT2 inhibitors were used at baseline is given as a strength, but the percentage is still limited, and we had a good Asian representation in this. Limitations being the MES scoring was not analyzed, and whether the baseline proteinuria was because of chronicity and not because of active disease is something we won't know. And the BP criteria at screening being 150/90, it's not restrictive. Probably with a better BP control, the proteinuria and the outcomes could have been better if the baseline population was better selected. The other study was a Jan ISN study, which was again a phase 2A study. Just wanted to show that there was a significant reduction in galactose deficient IgA levels and also proteinuria with the use of atacicept in the study also. This is the Origin phase 2B study, which shows that in addition to the current standard of care, there is a significant reduction in proteinuria at week 24 and 36. And following the positive results, the Origin 3 study has been started, wherein atacicept 150 milligram will be studied for worldwide across 376 participants. This is again something which is promising. Uh, the visual abstract which shows that there is a significant reduction in UPCR, stabilization of EGFR, reduction in galactose deficient IgA with a good safety profile with the atacicept. Something which I would like to again make a note of is the ALIGN study, where an atrasentan, which is a selective endothelin receptor A blocker, was studied in IgA nephropathy, dose of 0.575 milligram per day as against placebo. And in the interim analysis, which was published again in October in NEJM, it had shown that atrasentan caused a significant reduction, a 38% reduction in proteinuria as compared to placebo. So we're going to have more promising results in the complete trial, also in the phase 3 trial. Apart from this, in 2024, we had publications on cemdisiran, which is the interference molecule which targets C5, which have also shown reduction of proteinuria in IgA nephropathy. We had Ionis FB, which is an antisense oligonucleotide which targets complement factor B. This was presented in ASN 2024 again in October. Here also it had shown a positive response with regard to proteinuria and IgA. We also had presentations in WCN and ERA 2024 with Zigatibat, which is an anti-April monoclonal antibody, which reduced both the antibodies and proteinuria significantly in IgA patients, and povetacicept, which is a dual antagonist of BAFF and April cytokines, where the galactose deficient IgA was significantly reduced, and nearly two-thirds of the patient had achieved remissions, which was presented in WCN 2024. So all these are really promising trials which we are looking out to 2025. I still believe that IgA, it is a year of IgA, and we are going to have more trials and promising trials in the future. Thank you.
Thank you, Darshan and Arun. I mean, it was an excellent presentation. I think you've covered everything as far as the IJ is concerned, almost all the salient clinical trials that have concern and probably of much more utility in the coming up years. But then a couple of comments, like it is that in the applause study as well, 50% were Asian. In fact, we are fortunate to have the Asian group because it will be applicable more to us. The rest of the people formed about 58 or 48% or something like that. What's your comment on this? And then the most salient thing about all IgA trials is that they take the historical biopsy samples rather than the naive or the live biopsy, in the sense the biopsy samples which are of a 3-month-old or a 1-month-old. They take the historical biopsy samples and then they start treating it. So how do we look at this basis that, historical proven IgA nephropathies are treated in the applause study? It's about 1.5 to 1.8 years or 2 years or something was a gap after the diagnosis of the IgA nephropathy. That's another thing. And of course, as far as the applause is concerned, iptacopan is a breakthrough, but then the cost appears to be pretty high. When we calculate in INR, it appears to be 3,60,000 or probably $4,700 for 60 capsules. But then we need to appreciate that FDA has given an accelerated approval despite an interim analysis in August 2024. So we look forward for the use of it. But then still the answerable questions are, what is a long-term remission rate? See, we have seen at 9-month interim analysis, we are waiting for 2 years, and then we stop the drug. How is it going to be sustainable in terms of long-term remission or prevention of progression of the decline of GFR, which probably will get to know at the end of the 2 years? Then the dose, you have said 200 mg twice daily. In fact, the phase 1 has checked about 50, 100, 200 and all this. And then now we are at 200 mg twice daily. So is that the optimal dose for us? Is it going to suit the probably Asian group or whatever it is? And if you look at the studies as well, the C score is pretty less. The C was less. So how are we going to look into the acute, IgA nephropathy cases, like with sense of something showing to help.
Overall, as you have rightly pointed out, ma'am, I think iptacopan, it has shown some promise. As with all other drugs which are which are coming out in IgA nephropathy, the cost of almost all the drugs are going to be high. As against the other glomerular diseases, wherein the acute therapy is very important, IgA is more of a chronic disease. So the duration of therapy is expected to be longer, and probably our understanding in the disease is going to evolve, and we'll be able to know what will be the total duration of therapy for these diseases. the cost is going to be prohibitive. So I'm not sure what is going to happen. And none of the trials, I think, will be focusing on crescentic IgA because probably overall the outcome of crescentic IgA is quite dismal. So anyone who develops a molecule would not want to present a dismal response. Probably that is one of the reasons why they are not targeting crescentic IgA nephropathy.
And then the other comment is like the hypertension was pretty under control, 129/79. Though the proteinuria range was little less than 1.52 or something like that. We did not see a data of a high degree of proteinuria, of course, which is little rare in IgA. The blood pressure is very good under control. That's another point, probably, which I might have favored a very good effect. The other thing is, most interesting thing is SGLT2. Is this going to be an add-on to SGLT2, or do we get away with SGLT2 and go independently with iptacopan? The other thing is majority, in fact, 98% were RASIs. So, yeah, I mean, so these are little, overlying, or probably we don't know how to look at this, but then the future, what is it going to be with added on therapy, SGLT2, probably RASI and iptacopan? What's your comment on this?
I think that limitation is there with all the trials which have been published till date. I think we need a trial wherein patients are on optimal doses of both RASI as well as SGLT2 inhibitors, because considering the cost and the positive outcomes of the DAPA-CKD and other trials, and from our clinical experience, I think all the patients need to be on SGLT2 inhibitors if they are going to tolerate it. And the trials have to take in patients with these drugs for us to know if they have any added benefit. That is one. And two, we need a head-on-head trials. Most of all the trials are placebo-controlled trials, which we are using right now. Probably the head-on trials, after they are being conducted, may help us understand if one molecule is going to work better.
Correct. Another trial that I probably think you've missed out is Sanctuary trial, which is a phase 2 ravulizumab one, which has shown, in fact, a promising result again in IgA nephropathy.
Yes.
Of course, in some cases of lupus nephritis as well. So thank you. Thank you so much. I think we look forward for having iptacopan, because it's like another drug which can be used in a number of autoimmune diseases, whatever you have presented, which includes C3G. Actually, I was about to mention about Appear C3G, but then you have mentioned it already. So anyway, thank you. Dr. Darshan, excellent presentations, both, definitely they are the breakthrough achievements in the research and all this. We are moving from, invasive diagnosis in adults or presumptive diagnosis in children to an evidence-based, non-invasive method of, diagnosis of MCD or FSGS or whatever it is. And of course, they're very robust. They are supported with animal studies. There are longitudinal follow-up in few of the patients. It's very strong. But then, what is the real world data? See, we definitely, at the end of the day, we want to have a clinical applicability. And the major, I don't say the shortcoming, is that all the centers, Germany, Italy, all are European centers. How about the different race and ethnicity applicability? That's one question. And then the cutoff levels. In one of the study I had come across, like primary recurrent FSGS, the levels were in few lakhs or thousands. And then when you treat with the rituximab, it's going to fall down to, few hundreds or undetectable levels. So these levels are not seen in this study. That's one. Or probably, do Indians or Asians differ in these ANA levels when we assess with the futuristic to come? But then the robustness lies in the method of estimation. It's a combo or the hybrid assay of immunoprecipitation and ELISA, which they say they have achieved it with a great efforts. In the sense, it is not a single method that is used. It's a hybrid one that's used. But then the challenge is, again, is it available in the countries like India or in other countries? Because they themselves say that it's available only in research labs. It's not for commercial availability. So we probably have a little long way to go to have the ANA levels to be estimated in a commercial lab or something like that. And then the other thing that still we do not understand, though this may not be relevant to the present study as such, the reduction with the rituximab and all these things, how do we look at it? See, podocyte biology itself is evolving. There is like two trigger theory which is proposed for podocyte. Like there is a genetic, which is a stable one, upon which there's a trigger for the podocyte. Podocyte has a stress, it becomes vulnerable and susceptible and all this. So how does it come back to normancy, or how does it get affected because of the presence of anti-nephrin antibodies? And are they going to be removed in case like we think that the levels are pretty high? So these are the a couple of questions. And of course, main thing is, with respect to the Indian scenario, we need to think about the affordability and accessibility, which we think probably we probably have a long way to go. Darshan, over to you.
Yes, thank you. All relevant points. I'll start with the first. Most of the population has been Caucasians. Only the Japanese have been able to produce the ELISA-based test, wherein which they have tested in their population. And the study which talks about the recurrence is also from the Japanese cohort. Yes, they also found a similar incidence of anti-nephrin antibodies in close to about 40 to 50% of patients in the Japanese cohort. Chinese are now starting to test in their cohort. Definitely in India, I think we are a long way. What I've heard is All India Institute has got a grant to start these antibodies, and I think the pediatric nephrology will be rolling out these tests. But as you said, yes, if you are taking an immunoprecipitation, you have to take the ectodomain of the nephrin, then develop it, then use it with precipitation techniques. It is a long way to go, and ELISA and whether only ELISA can match the results needs to be tested, because ELISA is more simpler, can be more easily available, cost effective compared to the immunoprecipitation test. All the points are taken value. The, coming to the second question, how rituximab, whether rituximab causes reduction in anti-nephrin bodies, that has been seen in this study, in the one published in NEJM. Only, even though there were only 3 patients in that study, but they could see that how the peak of anti-nephrin body comes down with 2 doses of rituximab. Probably, yes, it could be a B cell depleted, even though, one thing they say is this is not a typical antigen antibody response. It is basically the endocytosis of the nephrin and the decreased expression of the following phosphorylation with anti-nephrin antibodies. There is endocytosis of nephrin and decreased expression of slit diaphragm proteins, which is the basic pathology. With rituximab, a few mechanisms. One, there could be a B cell depletion, probably reducing the anti-nephrin antibodies and thus bringing back nephrin to the slit diaphragm and restoring the parity. That could be one. There is also a mechanism where they say that restoration of T regulatory cell populations and upregulation of their functions are also implicated when rituximab is used. They also talk about suppressing permeability factors, especially the angiopoietin and VEGF. These are other permeability factors other than the SUPAR, which get suppressed with the use of rituximab. It also has a direct podocytic activity also, wherein it restores the SMPDL3B pathway. So these are both the direct and indirect ways through which rituximab acts. And definitely, so what the 2 studies said that is in children, especially because majority of the cohorts in them were children. So what they could see is in non-genetic cases, there is autoantibody mediated nephrotic syndrome of minimal change histology, where you can identify who responds to second line of therapy. That is the whole crux. So there is a cohort which is only nephrin antibody positive, and there is a cohort which has both antinephrin and anti-slit diaphragm positive. Anti-slit is again based on IgG staining of the biopsy, whereas anti-nephrin is a serum level estimation. And then there is another cohort of patients who are only anti-slit positive, with anti-nephrin being negative in the 2 ELISA tests that the group used. So one, the explanation that could be is they may not have picked up antinephrin, but there is a presence of, probably there are other antibodies which are there which could be playing a role. That is the reason they are antinephrin antibodies, but anti-slit IgG positivity, that could be the basically, they try to define the phenotype. They are basically very high proteinuric patients. The serum albumin is less than 2. Pediatric patients who are less than 5 years of age. They do, but the good thing is they have less of chronicity in them, and they do respond to second line of therapy, especially CNIs and rituximab, if they other than ARBs. So that is the advantage. So yes, they may not be available to us. We may still go on to have a trial and error approach for years to come, but having said that, there is a hope where we can do a personalized approach to these patients. Uh, a- uh, any other things you wanted? Yes,
See that study, anti-slit, it was like frozen biopsy samples. So,
frozen biopsy. Yes,
and the study was about 10 or 12 years, if I'm not wrong. I mean,
correct. Yes, ma'am.
22 or 24.
They are only steroid resistant nephrotic syndrome kids. Yes.
But don't you think it is definitely challenging and cumbersome to look at only the tissue samples for the check of the antibodies? Because if it is in the non-invasive sample, such as, I don't say non-invasive, a sample which is easily available, probably it will be more clinically applicable. But when you look at the tissue samples as such, and then you want to check it, like let's say when we correlate with the play2R, we are limited to looking at the tissue. We generally go for the serum. Okay,
Correct.
we have done it, but then what I'm saying, when you go into the routine application of the clinical applicability, the anti-slit being detected only in the frozen tissue biopsy samples limits our usage, and probably in identification of the so-called severe nephrotic syndrome, and of course the initiation of the advantage of the second line of the immunosuppression.
One thing what here is,
One more question, like the
yes,
availability of these high-end microscopes, do you think it's available? Because
no.
see, from Hyderabad, we have the confocal in NIN, CCM, but these are not available in every institute. Probably AIMS may be having and Manipal may be having, but these are not regularly available. Confocal or the STED and all these are not available regularly. So again, that remains a major challenge at least in our setups.
Yes. We have, but we cannot ask our tissue. We are not sending our tissues to confocal microscopy. We have only for research purpose. Again, it is of no use for clinical currently, even in our setup. So definitely, that's one of the limitations what the author also described. But what I could say about that is the way they have approached. So you are doing biopsies in only steroid resistant. So there is a tissue with you, and you have already have an antinephrin, which is you are checking in the serum. So in patients with antinephrin antibodies who are negative to it, so if you are able to identify an additional antibody, then they do respond to therapy. If you do not find in them, if they are genetic negative, antinephrin negative, anti-slit negative, they are less likely to respond to second line of drugs, and probably they are more likely to progress to end stage kidney disease. Only yes, there is a very small cohort who are antinephrin negative, anti-slit negative. This is only to identify, but practically at the end of the day, as you said, ma'am, I don't think all these biopsy tissues will go into the confocal microscopes. All these biopsy tissues will not be going through antinephrin titers. Most of them, we just are again going through a trial and error method. Start with them, do a biopsy. If there is no chronicity, start them on CNIs. Definitely, I think we will be doing that for a few years to now, but probably later. Yes, I think when things become much cheaper, I think we can still go ahead.
Yeah,
With
I definitely prudent not to load a patient who is genetic negative with an immunosuppression if he happens to be anti-slit negative also. It's worthwhile checking for anti-slit positivity, and so that we are a little sure in saying, okay, there will be a benefit in adding a second line immunosuppression and probably a response will be there. But then both the studies look like very fab and very innovative, very promising. But then when it is applicable to LMICs like ours, wherein the majority come from the public sector hospitals, it appears to be far-fetched, dream for us. But then if it happens to be in the next 10, 20 years, then we are good in treating or probably prognosticating and, of course, predicting the recurrence, especially in the diseases such as MCD, FSGS, and, of course, in children as well. So very good studies. And, of course, the cost remains still a major challenge for us in our setup. So it's not going to be easy for us. And how about a word I've asked about, how about the pheresis of this ANA? I mean, do you have any idea about ANA is high, so you ferrous ANA, I mean, the patient is going to be a little better. Are there any studies with that?
Recently, I did a literature review on recurrence of FSGS in pediatric transplant who are non-genetic causes, and they're not related to nephrin and antinephrin because that has not been done. But in that literature review, overall, without testing for the antibodies, what they realized is in patients with native biopsy of FSGS who have fast progressive, there is no point of doing plasmapheresis. There is no additional benefit of doing plasmapheresis. And the meta-analysis clearly said that even you can just prognosticate them, but plasmapheresis at that point, pre-plasmapheresis, pre-transplant plasmapheresis is not going to help.
Okay. So we hope that we are going to get away with biopsies probably in future, and then depend upon the serum levels of ANA and probably tissue levels of antislates, and then prognosticate, and then probably have the treatment optimized in the patients who are whichever antibody is positive. That's what we are looking at, and I hope we will be at that point in the near future. So thank you so much. A word that I just wanted to impress upon the audience is another trial which has made a major breakthrough in 2024 is the FLOW trial, which everybody knows about it. The FLOW trial has emphasized on the utilization of the semaglutide and all, and it is also emphasized for the 4-pillar treatment of diabetics, and then the treatment in non-diabetics as well. So the audience, we request them to go to the FLOW, which has been done in about 3,000 plus group. And of course, a meta-analysis of a club of FLOW and SELECT trials have also shown a sustained benefit of utilization of GLP-1RA. The other thing is the empagliflozin, the long-term effect of the empagliflozin. Even if after you stop the 12 months after stopping the empagliflozin, you have an advantage of sustained remission or reduction in proteinuria. This is another one which has come up in October 2024. And then the Valiant trial, which is a phase 3 trial of, pegcetacoplan in this. Yesterday I was hearing to Carla in KDGO GEMS. So they were speaking about this pegcetacoplan in patients with C3 glomulopathy. There's a Valiant trial again, which has again shown a promising result. And of course, the BP road trial, which is another trial which has shown that in patients of diabetes, there is a reduction in MACE, major adverse cardiovascular events. So these are the couple of the trials that I thought probably could are the top nephrology trials in addition to whatever you have discussed in the year 2024. A couple of questions, if we can take. I think you have answered them a little live, but then Darshan, I think this is to you. Why incidence of antinephrin, I think, is higher in pediatrics than in adults?
I mean, if you look at the ratio, it is almost similar, but only about 8% more. There was 54 and this was 44. The reason probably is, I think the number of patients with MCDs and podocytopathies is more. And you have other autoantibodies already coming in the adult population, like the membranous having its whole of antibodies. Probably when you take as a whole number, the percentage comes down. That's what I can say. It's only probably a number game. I would say it would be actual figures if you, that's what I would say.
Yeah, I agree with you, Darshan. And another question was there, like anti-plateau R, we check every 3 months. What about antinephrin? I don't think the
We
clinical
don't have these studies.
data of utilization applicability of the antinephrin antibodies. And then another question to you, Arun, is while conducting studies in IgN, is it the dose or duration of steroid intake more important?
I don't answer it because I don't know what to answer for it. But overall, I think the dose would be very important in case of RPGN like presentations. Apart from that, from an adverse event point of view, I think duration of steroid is what our understanding is evolving. Again, the Nefecon trial, initially we used to use only 9 mg for 3 months, and later it had become for a year right now. and the dose is also increased to 16 mg. So at present, we are not sure of the dose or duration of steroids, but higher doses are detrimental. Unless and until there is crescentic IgA, please don't use higher doses. I think the testing trial was testament to that. We had lots of adverse events with that. That is why the testing too had used a dose of 32 mg maximum dose. So I think lower dose for a shorter duration would always be good for steroids, irrespective of whether it is IgA nephropathy or any other disease.
So the
Please,
duration
you can
as
correct.
this KDIGO is like you have to repeat the cycles of the TRF, isn't it? I mean, it's though you give the in
Multiple
the
cycles
multiple cycles are to be given as per the KDIGO latest guidelines. So
guideline.
yeah, whatever you said, I definitely concur with you. Darshan, you won't add anything on that?
I think the controlled release once data is being presented by Dr. Sanjeev Gulati in WCN from the Indian data. I think that they're not the targeted, but the controlled one. Let's
Yeah. I think then we can probably conclude it. I think we are already late.
Thank you
yes,
so
thank you, ma'am. Thank you for
Thank you, ma'am. Thank you for such a wonderful and insightful discussion today. And as we are concluding this, we would like to extend a warm welcome to all the attendees and everyone from India to attend the WCN 2025 at Delhi. It is going to be a wonderful learning experience and would have lots of opportunity to collaborate. And it will be a very vibrant atmosphere. And thank you, ma'am, for joining us today. And thank you, all the attendees. We hope to continue our journal club as scheduled in the coming months also. Thank you.
Thank you so much. Thank you.